Hi, everybody. My name is Annique Forrester. I am a CL psychiatrist here at the University of Maryland. For the first 10 years of my tenure on faculty, I was the psychiatric liaison for the Blood and Marrow Transplant Center.
Good morning. My name is Angel Parker-Heffner. I come to you guys all the way from Memphis, Tennessee, from Regional One Health, our very brand new, a year old oncology program. So thank you for this opportunity. I'm very happy to be here today.
Okay. So I'm going to start with Dr. Forrester. Supporting mental health is such a critical part of taking care of these patients with these life-changing diagnoses. So how do you, approach a new patient when they are meeting you with that new diagnosis of that, blood cancer, blood disorder?
So for me, one of the things that can you hear me? Okay. One of the things that I tried to do was really have the patient tell me what their experience was. So rather than assuming how the diagnosis would change sort of their mental health or how they were doing, really just kind of saying what has happened, how did you find out, how have you been coping with it? A lot of patients have been fairly healthy before any diagnosis. Regarding a blood disorder. And so it's fairly shocking. And a lot of folks are struggling actually more with the idea that this thing was going on in my body and I didn't know about it. So there's some guilt there. There's some sort of concern, like, what does this mean for me moving forward? But I really just let the patients tell me their experience rather than assuming one thing or another. And for the most part, I found patients to be very resilient. So depending on people's support system, their history prior to this diagnosis, many people were sort of ready to engage with their treatment, looking forward to a transplant if that's what was being recommended, kind of feeling like I'm going to beat this rather than feeling sad, depressed, anxious. That actually was the minority of my patients.
Yeah. So for Ms. Parker-Heffner, a lot of our patients spend so much time in the infusion center. As someone who's played an important role in establishing a new cancer center, what have you done in the infusion centers and in the, waiting rooms and clinic rooms to really help our patients with these blood cancers and blood disorders?
I would say our infusion center was pre-established. The oncology piece was fairly new. And so with that, our patients, we had no policies or anything in place, when we decided to start treating patients with bone marrow failure. And so some of the biggest things, one thing was access, getting them there. We had such a huge cancellation, probably the first 6 months we were open, if we had 20 patients scheduled, we maybe would have 8 to show up or 10 to show up. And so one of the bigger things that we did, we reached out for a grant, to help with transportation. So now we have a ride share program that was sponsored by the American Cancer Society, where we can provide transportation just to get them to the appointments, because that was a huge thing. On top of our patients, coming from inner city Memphis area, that's a huge struggle, a huge barrier. So just for those patients to not have to worry about getting to the appointment, we made sure that they would have the transportation there, round trip transportation back home. That took like a worry away from them. Also within our infusion center, it took a lot of training for our staff, for the different patients that we would be treating with the bone marrow failures. For our patient themselves, I will say that they were all very eager, to be able to come to the infusion center to get their treatments, not have to come inpatient. Well, in the beginning, inpatient didn't exist. So outpatient infusion was open for about 6 months before we were able to even admit them inpatient. So to be able to come, it started off being like an all-day process, because we had to work with pharmacy, we had to get labs, wait on the labs to come back, then get the treatment order. So it went from, just being very, I felt like chaotic for the patients to now is more streamlined. We do have a process when they come in, we have a better process of going ahead, getting the lab so we can get the results back, so we can get the chemotherapies and get the treatments ordered. We have like a little packet that we have for them. It's kind of like a wellness packet with like all the good snacks that we have. They got really good snacks in infusion. Each little area, one thing that we did not have prior to, they didn't have like a television or anything to keep them engaged. So now it's only 12 chairs chairs that we have, but each chair has like their own little television. So it was a progressive, and still we're progressing, but those were just some few things to like help them with these newer diagnoses to feel a little bit more comfortable, you know, and to also take their worry out to just actually get into the chair. Again, we are very thankful because we're so new, you know, and our hospital is known for trauma, you know, and so when the oncology piece came about, we did have just so many different entities coming to want to help us. And so we just reached out, you know, Hope Lodge is like less than a mile from our cancer program or from our hospital, just based off other established programs in the area. And so we met with them. We still meet with them like monthly, and they're like, anything we can do to help, anything we can do to help. And we were like, transportation is a huge issue for us, you know, and a lot of our patients, they will want to come in for the treatment. They wouldn't have ways to get there. I have a story just this week. We have a patient that was supposed to come inpatient actually on the 13th. Waiting on insurance verification. They cleared him to come on the 15th, you know, and so the 15th we call, we like, hey, you coming? He's like, yeah, I'll be there at 3. We like, okay. We call back about 4. He's like, oh, I don't have a ride. No problem. We sent an Uber. He missed the first Uber. We sent a second Uber, you know, to get him. And he's like, well, I'm not quite ready to come today. I'm gonna come first thing in the morning. So Thursday morning we call, or Wednesday morning we call, like, hey, you know, you ready and everything. We call him and his family like, oh, he passed away this morning, you know, passed away at 5 o'clock this morning. So when I reached out to my physician, his primary, to say like, he never came, like when we called back, you know, they said he passed away, you know, just another barrier that we see with some of our patients, you know, because he was so focused on getting all his things together at home, you know, on top of the insurance delay and then his delay, he wasn't able to get the treatment, you know, that could have prolonged. And so back to your question, I'm sorry, but just reaching out to those resources and, you know, being very vulnerable, letting them know that we are brand new, you know, we're a brand new oncology center. And one of the reasons why I'm here, because I want to learn from so many of you guys that are at academic medical centers and have comprehensive cancer, working for comprehensive cancer centers. And so just really being very vulnerable and asking for the help, saying, hey, I'm trying to figure this out. I was telling them when I came there, I was the only like certified chemotherapy nurse in the building, you know? And so I'm very vulnerable. I worked at St. Jude that had all the resources. So I know what it takes, and just asking for help, you know, and not being afraid to tell people we don't have it figured out. We think we might be doing it great, but we need help.
Oh. Yeah, agree. So I want to welcome Sharon Telesford, a PNH patient. You want to introduce? So my first question to you was, what was your experience like in the workup that led to your diagnosis? What was
it all started with me having a low blood. So I was anemic. And so my doctors felt like there was something else wrong with me. So he sent me to a hematologist. Hematologist decided to run some tests, which they did a bone marrow aspiration. And they came up saying I had MDS. And I actually came to this hospital to get a second bone marrow aspiration. They also said I had MDS. And then some time had passed, and they were talking to my family, seeing it, you know, if anybody had the same blood type. So I also decided that I would go get a third opinion. So with the Sloan Kettering, and they ran some tests as well, and they said I had PNH. And then there began my journey, my real journey for PNH.
What was that time period from that anemia diagnosis with your local doctor to that final diagnosis of PNH?
So I think in 2006 was when it all started. Months had passed. I think I went to Sloan Kettering because I think I came here a couple of times. Yes, and then Sloan Kettering, that was 2008. So that was like in January. And I felt like they told me what kind of treatment I would need. And I felt like, oh, I don't want to take that medicine.
Oh.
So I waited till like all the way till December because started getting worse. You know, really fatigued, really tired, just not being able to overcome what I thought I could normally overcome because I was in good shape, good health, physically used to run, dance, everything. So I felt like I'll get over this, but that did not happen. So in December of 2008, I decided to start the treatment. Start, the process of the treatment. I had to get the meningococcal vaccine and all that before I actually started, like almost a year later after officially being
What was your hesitancy with treatment,
diagnosed.
if you don't mind me asking?
I don't like taking medication. And I felt perhaps that it's going to be traumatic to my body. Being not a real athlete, but self-certified athlete. I didn't want anything that would be too harsh on my body. So, because I felt like it was a type of chemo and they didn't have an end date. And I didn't know how long I would have to be going through. And I just felt like I would get over it. So it was just me getting the medication that was my.
What was the biggest life change with the start of treatment for PNH?
So when I started, I did see, of course, a change in my body. I'm so hot, sorry. From running, trying to find it. I started getting a sense of normalcy. And a normalcy I didn't know was missing from my life.
Right.
Because I had been anemic. I've been borderline anemic. But still I could always function. But of course, when the PNH really set in, and I realized, how bad it had gotten once I started the medication and felt like, oh, okay, I'm coming back to life and coming back to myself. So like, oh, this really works. And it did work for some years. And then like maybe 5 years in, I started needing blood transfusions. So that took on a whole nother life for me.
Oh, absolutely. Now, Dr. Forrester, what is your experience like trying to get insurance approval for our patients to see you?
So typically, because I did work seeing folks in our Stoller outpatient pavilion, as well as seeing folks for pre-transplant evaluations. The pre-transplant evaluation piece was actually easier than the regular outpatient piece because the psychiatric assessment is sort of built into everything that needs to be done for a patient pre-transplant. But for general outpatient mental health, there are a lot of obstacles that many of our patients have to go through depending on what insurance they have to be seen by a psychiatrist. So access to care is a huge issue. Every insurance does not handle the mental health carve-outs exactly the same. And so a lot of patients ended up not being able to see me. And so I never personally had to obtain the insurance, but we had a lot of folks that, had some issues. Now we do very well with Medicaid patients. They have very good ability to see us, but a lot of the private insurance, no. And so, yeah, I think the pre-transplant aspect of it made it easier because it's bundled in. And I think that's the biggest lesson for me is like for the mental health care, to really make sense, we have to start shifting our thoughts about mental and physical health. Because when it's bundled in with the physical health, it's easier for patients to access versus if it's something separate.
Yeah, which is for Ms. Parker-Heffner, my question as a physician is, a lot of times my nurses tell me that the patients come to them in infusion asking, questions about their treatment and their side effects. What can we as physicians do to have our patients more informed so that they're not coming to you because you're more approachable?
I would say, one good thing I would say at Regional One Health, we have like a very decentralized approach to our patient care. So all of our physicians, the nurses, the nurse practitioners, just because we're such like a small team and, we're growing, but we know that we need each other. And so when the patients come in, if they have questions or anything for us that are above what we can speak to, which is a lot of the stuff that was presented today from the physicians is kind of above us, right? But we collaborate. So I feel like the collaboration with the nursing staff, the clinical staff, the social workers, like so important. And also with the patients. And so the biggest thing is putting the patient's needs and concerns first, and that's one thing that even from, when we sit down to interview applicants or whatever it is, it's very decentralized. We want to talk to the patients and we want to appear human. And so that's a big thing, from the physician standpoint. And the great thing with the majority of the physicians that I work with, like we're all human, right? We have great days, we have bad days, we get it right sometimes, we get it wrong, but being vulnerable, being transparent, and always putting the patient's needs first. With our patient population, they look very different. They look very different. With some of the stories that Dr. Amadi told, I don't have many patients that have, I'm sorry, Dr. Blue told, I don't have many patients that have franchises. I have a lot of patients that don't have places to stay, and so the social support is so important. And so the biggest thing is like listening to the patient and, always understanding that we are all human, we're all fighting different battles and that we're all a team. That's the biggest thing. We don't have like you're a nurse practitioner, I'm a doctor, you're the patient. No, we all have to be equal in order to meet the needs of that patient. And so I think that's the biggest thing, just that open communication, the transparency in placing the patient and their needs at the center.
So can I ask you to address the same question?
Yeah. Myself.
Okay. I feel that there is a lot of information out there. I've been on this journey so long, because it's been 15 years for me. And for me, I guess I don't even too much look for information. It's like I feel like, dude, I'm old patient from but I do feel that there are resources out there. There are a lot of resources out there for PNH. So I don't seek it anymore because I feel like my life is so normal now. It feels normal. So I don't seek, maybe so much like maybe a new patient just really starting their journey will be more so looking for information, but.
Hard time for a lot. It's something that you like. Word, Google, something you use that like that means like what led
What led to that was when the doctor said, "Oh, about a good 15 years to live." And I was like, 15 years to live? That whole thing of, I'm going to die in 15? Are you serious? So after testing all my siblings and no one was a match, I was scared. And my sister's best friend, she had cancer. And she thought she was going to die. She went to Sloan Kettering, and she went to remission, and she's been fine ever since. And hers was probably 20 years ago when she went through that whole process. So let's see, since that worked for her, let me see if that'll work for me, if it's something else there, because they're specialists. I wasn't going to a PNH specialist. I was going to hematologist.
Mhm.
And the doctor I chose to go to was an MDS doctor, actually. And, after he was like, I don't know if you have MDS. So that's what led me. I felt, because I had that outlook with my sister's best friend. So I chose that place because of her, probably. And the part about me dying, so.
Absolutely, absolutely.
Right, you're in.
So the MDS doctor who I did see, and when he said, hey, I have great news, I have bad news. The great news is, well, the bad news is you don't have MDS. The great news, you have PNH, which now there's more of a survival outcome. But because they were saying it is so close to two illnesses, it's so close, I didn't hold it against anyone for misdiagnosing me. Because even my first doctor who misdiagnosed me, he's still my doctor today. He is my hematologist. I think he's great. I never held it against anyone for misdiagnosis. But I am glad I sought a third opinion, because I would have started a treatment of chemo, so to speak. I would have been on the wrong treatment, and who knows where that would have led me.
Absolutely, absolutely.
Dr. Annique, I actually have an online question for Dr. Forrester. And for the panel, what are your thoughts in regards to EAT and CAM, or expressive arts therapy and complementary alternative medicine, to address mental health issues?
So I think they're fine. Like, I have no specific issue. I think any therapy has to be tailored to the patient. And so if you have a patient who is interested in those modalities, then it's important to kind of assist them to getting there, but also to stress that level of communication. But also, like, if I'm the psychiatrist and I think you have a significant mental health issue that requires medication, then I'm going to tell you that. And I think a lot of people think, for mental health issues, I don't need to take medication. And that may or may not be true. And so it's always the both and.
Yeah. For the Dr. Forrester, you brought up the need for medications, and there are a lot of a stigma involved, especially in patients of different backgrounds and culture. There's still a huge stigma of having a mental illness, even now today. How do you approach that in these patients?
So again, for me, and the way that I'm able to kind of start that conversation is sort of, what does this mean to you that we're talking about this? How does it feel for you to be seeing a psychiatrist today? Especially when I was doing the pre-transplant evaluations, because it would feel kind of strange to them. Like, why do I have to see a psychiatrist? So we would actually talk about that. And just kind of normalizing how significantly life-changing having a diagnosis like this is, that is actually okay. So we're not trying to pathologize any sort of distress that you might be experiencing because of this diagnosis or because of the treatments that you are hearing about from the hematology oncology folks. But then also really having a more specific conversation. And I think this is why psychiatrists are important, because in the mental health sphere, we use a lot of the language very colloquially. I have depression, I'm anxious. But to have a disorder is something separate that really needs clear diagnostic questioning, and you have to go through an entire process. So once you explain that to somebody and you actually go through the process of asking the questions, by the time you come to the point where you're saying, this is what I think is going on, the patient has gone on a journey with you. And so it's easier to kind of combat the stigma issues and kind of talking about what are the options. So if medication is not the first option, I'm not going to lead with medication. We're going to talk about therapy. We're going to talk about supports. But if I'm feeling strongly about medication, we've gone on a journey and I'm going to tell you why. So the stigma piece, I think, comes from people really not having a clear idea of what it means to have a mental health diagnosis, feeling lots of feelings about that just because what we see in our culture, and also because it's been separated from our physical health. So my whole career has been like, we have to integrate this. This is the patient, right, has everything. There is no psych patient. There is no, I have this disorder patient. Patient is going to have problems of every kind. And so they're all happening in the same person. And we have to kind of start to orient our care that way. And that's the best way to kind of address stigma. When we silo the mental health care, when we say, oh, you have to see a psychiatrist, and the way we do that, and the way we kind of refer people, the warm handoff. Dr. Hardy used to call me all the time. I have this patient, and then I could say, well, yes, Dr. Hardy called me and told me about you. And that's a different conversation, especially when we're getting into serious mental health issues.
So for Ms. Parker-Heffner, one of the kind of themes has been caregiver support. And we oftentimes, overlook the caregivers who are bringing our patients to us. As you have built the Cancer Center, what are your thoughts on integrating caregiver support into your overall Cancer Center plan?
It is very, so very important, and also so very challenging. I would say on the inpatient side, our patients with bone marrow failure, different leukemias, their average length of stay is like 11 days, so you're looking at 11 days that the patient is here, their family is here, and we have to be creative. We have to seek resources to support the families while they're there. No one will want to, if they could afford, having to pay for 3 meals a day in the hospital cafeteria. And so me and my true transparency, I reached out to our foundation, I'm like, hey, I would like some money, to purchase meal tickets for the patients, in case, they have different palates, they want different things, but more so for the families, one good thing about us being new, our hospital, it is very dated, the equipment is very old, but with us being new, we were able to get all new things. And most of the things I was able to select. And so even to the recliners, we wanted to make sure that the recliners that the caregivers would stay in were kind of, comfortable, not like the Four Seasons, but something better than what you would normally get. And so like all of those things, I think back to myself, my mom was a cancer patient when I was 12. So I think back to like all of her treatment and all of the stays in the hospital, as well as my experiences working at St. Jude, as to how can it be better? Because there is a better way, right? We might not have all the money, we might not have all the answers, but there is a better way. And so also when we're doing the education or anything that we're trying to implement, for our patients, we have to consider the caregivers, just because they are as equally as important. Their mental health is as equally as important. A lot of times with our patients, sometimes we wish they had more caregiver support, because they come alone. Sometimes when you're faced with coming alone, you don't come at all, just because you need that support. And so in the, with our limited resources, again, I'm going to ask for help, and to make sure that it's going to benefit the patient and as well as the caregiver. But I do feel like that a lot of times the caregivers are on the sideline or they're in the background, because oftentimes we're focused on the patient, but we have to consider them. They're there with us. Like I said, our patients stay for a long time. And so we have to consider their needs as well, which does not always play into insurance reimbursement or, like the financial piece of it, that's not calculated in, that this patient's wife, they're their primary caregiver. She's not going to leave his side, but she still has to eat as well. She still has to be comfortable as well. And so as we continue to grow, my hope is that, working with our social services, our case managers and our social workers, and the good thing about it, because we're so new, we're kind of able to like write our own story, and kind of put things in place the way we see best. And so working with my physicians, that's a huge piece. As we get more money, we get more funding, we're looking at how do we improve this for the patient? How do we improve it for the care? It started out very small. I'm thankful for our meal tickets, thankful for our recliners, but always just remembering that, we have to provide that patient family-centered care. It's not just the patient, because I tell my staff all the time, they're here with us for a short time. when they go home with their family, we should be giving them the tools while they're here with us for them to continue the excellent care that we're giving. So when it comes to the education, so very important, you know, because as a patient, you get so much information at once, especially when you're newly diagnosed or with the different treatments. So making sure that we involve their caregivers and give them the information in terms that they understand, bringing it to them and feeding it to them in terms that they understand, because if they don't understand it, they're not going to be able to do it. So those are just some of the like newer things or some of the things that we're trying to do to involve the caregivers and make sure that they stay as important and in the forefront, just like the patients.
Thank you so much. Thank you for our panelists.
Thank you.